Hi there, I'm Josh Lumley. I am the Vice Chief Medical Officer for North Star Anesthesia, and we're going to spend the next minutes talking about organ donation. So let's talk about liver transplantation. So indications for liver transplantation is going to be chronic liver disease with progressive deterioration in function and life-threatening complications. So that can be fulminant or subfulminant hepatic failure, progressive encephalopathy, jaundice, and coagulopathy. Non-cholestatic cirrhosis, biliary atresia, cholestatic liver disease, neoplasms, and more. Absolute contraindications for liver transplant include all of these except age greater than 70. So all of these are contraindications. Age is not a contraindication. So you can be over 70 and get a liver transplant. Absolute contraindications: active substance abuse, AIDS, active sepsis, relatively absolute, irreversible pulmonary hypertension, bad CAD, an extrahepatic malignancy, or a patient's inability to comply with the extensive and rigorous immunosuppressive pharmacology. So what we see here, it's patient survival is not as good as what you would see with the liver transplant, but you also see that, with the kidney transplant, but what you also do see is that by and large, a living donor is superior to a deceased donor for all of these hosts of transplantation reasons. Previously, we decided where a patient went on the list for transplant based on their child Pew score. We've now shifted to the MELD score. So all of the following are components of the MELD score except B, albumin. So MELD is characterized by the model for end-stage liver disease, and the components are creatinine, bilirubin, and protime. And so in this case here, it's capped at 40. So most patients that are between 25 and 40 are going to receive a liver transplant. And what we see, MELD score of 40 is the worst. The probability of death, of mortality, is basically 100%. We see that anywhere from 25 to 40 is where patients start to get their transplants. So with liver failure, they have total body hypervolemia. So they have edema, ascites, pulmonary effusions. They're hypovolemic, but they are intravascularly hypovolemic. They are coagulopathic, poor synthetic function of a whole host of liver synthesized agents, such as your clotting devices. They have poor synthetic function. They are metabolically deranged, hepatorenal syndrome. These patients are well known to have encephalopathy. They have splenic sequestration of blood, and they have portal hypertension with varices as well as the caput medusa, and then they're known to result in the hepatopulmonary syndrome. So in patients, as I talked about, the synthetic function is adversely affected. So with end-stage liver disease, they have a significant coagulation disorder. So they're procoagulant factors, that being 2, 5, 7, 9, and 10, and protein CS and antithrombin 3, they're all decreased. They have thrombocytopenia due to splenic sequestration, and then their fibrinolytic system that includes plasminogen, alpha-2 antiplasmin, and factor 13. They're all reduced. So just remember that all of your clotting agents that are produced by the liver are all deranged when a patient has end-stage liver disease. So these patients may, in fact, be thrombotic. So they're known to have portal vein thromboses due to, at the time of surgery, due to administration of antifibrinolytics like aprotenin Amicar, TXA, etc. So similarly with the administration of these agents, because their fibrinolytic system is so messed up, they may also have a thrombus that develops in the cardiopulmonary system. Again, you want to note that we definitely want to look at coagulation function at the time of transplantation. So these patients are known to also develop a combination known as hepatopulmonary syndrome. So they are hypoxic and their A-to-A gradient is greater than 20. So they typically have intrapulmonary shunting, and the absolute indication and solution to cure this is going to be liver transplantation. So pulmonary hypertension may worsen after transplantation. So in these patients, you will in fact place a PA catheter. So you're going to look for a mean PA pressure of greater than 25 and worsening pulmonary vascular resistance. So what are some of the diseases that can cause liver failure? So alcoholism, hepatitis C, hepatitis B, which is affiliated with liver cancer, primary sclerosing cholangitis, and biliary cirrhosis. And you should note that all of these diseases all have non-liver effects that arise from the disease itself. So for setting up the operating room, we want to be ready for aggressive transfusion. So in this case here, we want to think about two lines that are set up through warmers, an A line, a CVP, PA catheter, rapid transfusion, type and cross for oodles of blood, FFP, platelets. Consider the TEE, but always beware about varices. Standard induction, and then you've got to have your resuscitation medications ready and to administer with that neohepatic phase. So that's a really, the setup for it is enjoyable. Lots of lines to play. So lots of large bore volume lines. So RICs, CVPs, cortices, etc. An A line, a PA catheter, and preparation for veno-veno bypass. So veno-veno bypass is rerouting of the blood from below the diaphragm up to the IVC interrupted. So what that is going to do is increase your preload. Surgeons, some do it, some don't, and it is done when the patient is identified as at risk of having had IVC clamping, which can worsen clotting. So one end comes below, one end goes above, and it returns to the heart. So one of the advantages of it, of course, is you can avoid intestinal ischemia. You optimize drainage of everything distal, so the renal veins, but it's getting back to the heart. So now, of course, you're increasing your preload, and so you minimize hypotension, and you avoid the buildup of those acid metabolites. Of course, the problem is it's complex. There's a lot of heat loss, and you have the risk of air embolism with it. So there are three parts that you need to remember for a liver transplant. There's the pre-anhepatic phase, so the hepatectomy phase, the anhepatic phase, and the neohepatic phase. So with the pre-anhepatic phase or the dissection phase, that's where you're going to lose a lot of blood. So you need to be ready to transfuse. With the anhepatic phase, that is where you're going to have worsening toxic metabolites and acidosis, and you're going to have worsening coagulopathy. The neohepatic phase is where you're going to have a release of all of those metabolic toxic metabolites, and you can have profound hypotension. So with the dissection phase, you just need to be aware there's lots of dissection there. There are lots of structures that are well perfused, and you need to be prepared for significant blood loss during that phase. So hypothermia, be prepared. You need to have that patient warm. With arrhythmias, whether that be handling the kidney or with the compression of the IVC or with the neohepatic phase, do be aware of hypocalcemia and hypomagnesemia. You need to be prepared to correct that hypocalcemia. And then obviously hypokalemia, which can arise, and obviously hyperkalemia in the neohepatic phase. So in that dissection phase, management is basically just like a large exploratory laparotomy in a patient with liver failure. So you need to be prepared for good volume repletion, as well as significant blood loss and optimization and preparation for the anhepatic phase. So during the anhepatic phase, as we talked about, the liver synthesizes, even if it's poorly functioning, it still does synthesize a variety of procoagulant agents. When you remove it, you lose all of those. You also lose lactate metabolism, you lose gluconeogenesis, and you lose citrate metabolism. So you need to be prepared to treat hypocalcemia, metabolic acidosis, as well as hypoglycemia. And be prepared for fibrinolysis, and beware that you may need to use antifibrinolytics during this phase. Also, if you're not using the Venovenous bypass, you're going to have decreased preload, so these patients may in fact be significantly hypotension, so you may need to give them a vasoactive agent. In this neohepatic phase, do bear in mind, so now you've got a new kidney that's been ischemic for an extended period. They may have significant hyperkalemia, so be aware, have lots of calcium available, and be prepared to give epi in those cases in bolus doses. So what you see early on, if the graft is going to take, is correction of acidosis. The surgeon can look for bile production. They're going to maintain their serum calcium, potassium, and blood glucose. They're going to have an increase in body temperature, and their coagulation state is going to return to normal. Obviously, in that post-reperfusion phase, up to 1 in 3 patients is going to have this. This is going to appear within first 5 minutes of liver reperfusion. You see significant hypotension, and it's treated with epi and avoidance of hyperkalemia. Like I said, very significant hypotension with reperfusion syndrome. Be prepared to treat it with epi. So how do we manage it? Bring potassium to normal levels. Correct your lactic acidosis. Make sure you're transfusing them and giving them adequate volume. Have calcium ready to bolus. Have a ton of it on your backstand. Diluted epi for bolus, and have epi ready for an infusion. After your reperfusion, it can actually get worse. So it is hypothesized that some of the causes are due to the high potassium concentrations in the preservative of the liver, the demographics of that patient, a suboptimal graft, or use of veno-veno bypass. You've got to be prepared to put that patient on inotropes to survive this section. Afterwards, we rarely extubate them in the operating room because of volume status. We typically take them to the ICU to make sure that their coagulopathy improves and that there is no post-reperfusion injury or post-reperfusion syndrome. And then, of course, you'll want to remove those lines if at all possible. Certainly, the coagulopathy and the nature of the surgery lends itself to significant volume loss. So you want to have a ton of blood and products available and be ready to use a level 1 transfuser in these sorts of cases because the volume shifts are dramatic. What to watch out for: bleeding, bile leak, primary non-function of it, or hepatic artery thrombosis. In these sorts of cases, it's difficult to survive. Those patients require immediate retransplant. In children that are undergoing transplant, the most common causes are cholestatic liver disease, hepatic failure, or metabolic liver disease. You can transplant a portion of a liver in those cases. And this is purely theoretical. It's rarely utilized, but Xenon anesthesia for liver transplant surgery, it's been done 4 times. It's a hypnotic analgesic, not metabolized, rapid induction, and emergence, so it's not dependent on liver metabolism, no vasodilation or negative inotropic properties, and it's great for protection from ischemia reperfusion injury.